Hello and welcome to the next installment of our critical care curriculum. My name is Dr. Mike Infeld. I'm a staff physician in the intensive care unit at Metro Health Medical Center, and I'll be discussing precision extubation, or how to successfully liberate patients from ventilators. The when, why, how, and what if. Extubating patients and liberating them from positive pressure ventilation is probably one of the least precise things that we do in the intensive care unit. However, we're going to go over some topics today to see if we can use the data available to help to make this decision in an expeditious and wise fashion. When is the right time to extubate a patient? Well, we know that positive pressure ventilation is an unnatural mode of ventilation, since normally we suck air into our chests, and that there are numerous ill effects that are brought to bear when the air is blown into people. So we would like to do this as soon as we possibly can. However, we also realize that reintubation is associated with numerous bad outcomes, so we must be careful about when to separate patients from their positive pressure ventilation. Lastly, we're going to go over some therapist-driven protocols that help the precision of our decision to extubate. In 2018, if somebody is in acute or acute on chronic respiratory failure, positive pressure ventilatory assistant is the standard of care. Because air can be forced into the chest faster than the lungs and thoracic cage can expand, there's potential for pressure or volume damage to the lungs and impaired left ventricular filling, which has the downstream effects of decreasing cardiac output, substrate delivery, and can have untoward effects in almost every organ system that a human being possesses. We also know that the presence of a large plastic tube through the airway is a source of discomfort, and that the analgesia and sedation that we administer to overcome this discomfort can lead to deconditioning, both of the respiratory muscles and also in a global perspective. A failed attempt to extubate a patient is associated with a 6-fold increase in hospital mortality, as well as increased lengths of stay. So how do we figure out when the time is right? Well, there's really two parts to this. The first part is, have we reversed the cause of respiratory failure that made this patient need to be intubated and mechanically ventilated in the first place? You can see that I've divided this actually into two parts. One is the competence of the airway. Is the patient able to maintain patency of their airway without a plastic splint in place? And the second is respiratory failure. Can the patient's respiratory reserves meet the demand that his body has placed metabolically on the lungs to provide oxygen and remove carbon dioxide? If the answer to that first question is yes, then we need to ask 3 more questions to more precisely determine the timing of extubation. First is, can this patient safely endure a breathing trial, where the patient is asked to breathe on his own unassisted through the endotracheal tube to help us determine about the relative risk of reintubation. Secondly, if we've done the trial, does the trial indicate that that risk of reintubation is relatively low? Our respiratory therapist-driven protocols can help us to answer this question. And lastly, even if the airway was competent when we placed the endotracheal tube for respiratory failure, is the airway competent now that has been exposed to several hours or days of a foreign body in the trachea? Is there gas in the tank? The G being good gag reflex, the A being an air leak, and the S being secretions and the ability of the patient to handle the removal of those secretions that may have built up while they were incapacitated on a ventilator. If the answer to all these questions is yes, then the patient is ready for extubation. We know that a respiratory therapist-driven protocol assists us in removing endotracheal tubes and separating patients from mechanical ventilation in a timely fashion. Ellie et al. Published one of the first studies to look at a protocolized weaning maneuver, and this was published about 20 years ago in the New England Journal of Medicine. Several subsequent studies have borne out the importance of a protocol in this endeavor, and they all have several aspects that are common. The first is they are driven by respiratory therapists. That a breathing trial is initiated automatically without a physician order as long as there is nothing in a preset exclusion criteria that would mitigate against performing the breathing trial. The less exclusive the criteria are, the more rapidly patients will be separated from mechanical ventilation. Lastly, the breathing trial should occur in coordination with a holiday or respite from the analgesics and sedatives that are being used to overcome the discomfort of the patient due to the endotracheal tube. At our institution, we use the Richmond Agitation Sedation Scale. We want patients to be brought to a level of 0 to -1. That is alert or only slightly sedated, to be able to give them the best chance of being successful in performing their spontaneous breathing trial. Exclusion criteria that we use include a positive end expiratory pressure over 5 centimeters of water, a minute ventilation of over 15 liters per minute, a fraction of inspired oxygen of over 50%, or tachycardia with a heart rate over 140 beats per minute. 5, 15, 50, and 140. Clearly, the PEEP and FiO2 being at high levels would connote a large shunt, which would put a lot of demand on the respiratory system. Minute ventilation of over 15 liters per minute again is a sign that the respiratory demand is very high. Heart rate of over 140 means that the cardiac reserve to meet that demand may be insufficient. Two other important factors to exclude the patient include the use of vasoactive drugs, in other words, hypotension requiring pressors, and the presence of a ventricular drain. The presence of increased intracerebral pressure that necessitates an external ventricular drain would be another contraindication to a spontaneous breathing trial, with the possibility that the stress of the breathing trial would further increase the intracerebral pressure, being the mitigating factor. The last factor would be cardiac ischemia. Does the coronary artery give us enough reserve that we can get by with additional stress in terms of cardiac output to the respiratory muscles without risking myocardial damage? Pre-screening with a rapid shallow breathing index used to be used to determine whether or not patients should be allowed to have a breathing trial. Data from several studies, including those of Tanios et al., have showed that this does little to increase the ability of the breathing trial to predict successful extubation, but does significantly slow the time to remove the endotracheal tube. So these screens are no longer used. We do a breathing trial by doing this in concert with a sedation holiday, as I mentioned above. The holiday usually starts between 7 and 7:30. Once we have achieved that RASS score of 0 to -1, respiratory therapy will switch from their support mode, which is usually assist control, volume cycle ventilation, to CPAP. This is going to happen sometime around 8 in the morning. With a peak level of 5 and the FiO2 set to their prior support oxygen level and a rate of 0, the patient is allowed to breathe on their own. Vital signs and data are collected during this breathing trial, including a rapid shallow breathing index that we'll talk about in a minute, and potentially an arterial blood gas at the end of the trial if the patient has a history of hypercapnia. This is not mandatory. Once 60 minutes have passed, if the patient has not failed prior to that, they are switched back to the prior support mode at about 9 o'clock, and the respiratory therapist finds the team and presents the data, so a decision about extubation or not can be made. The rapid shallow breathing index was first reported by Yang and Tobin about 3 decades ago. It involves an index that has some predictive value about the success of trial of extubation after a spontaneous breathing trial. The RSBI is calculated by taking the respiratory rate in breaths per minute and dividing by the tidal volume in liters. The magic number here is less than 105. An example being respiratory rates below 30 to 32 with tidal volumes right around 300 cc's. If patients meet this criteria, the negative predicted value is about 95%. That is, if they do not meet this criteria, they have a very high risk of needing to be reintubated. If they do meet this criteria, however, the positive predictive value is rather poor. The initial studies were done with the RSBI calculated after 2 minutes of spontaneous ventilation. We can increase the accuracy with the area under the receiver operating curve going from 92% versus 74% if we do this measurement after 30 minutes of spontaneous ventilation instead of. How do you fail a spontaneous breathing trial? Well, if your respiratory rate is over 35 for 5 minutes or more, your heart rate goes again above that tachycardic threshold of 140 beats per minute, or you have a fluctuation in systolic blood pressure, either under 85 or over 200. Those are all vital sign criteria that say that you are not ready to meet your respiratory demands on your own, and the spontaneous breathing trial is interrupted. Any oxygen saturation below 90% for 30 seconds or more will also result in early termination of a spontaneous breathing trial. If the patient is taking no spontaneous breaths, they will automatically trigger apnea ventilation, and the machine will convert them over to an assist control volume cycle mode immediately without intervention of respiratory therapy. If the respiratory therapist feels that the patient looks distressed, even though they have not met these prior failure criteria, they may place the patient back on an assisted mode. Passing the breathing test really requires 3 things: that you spend 60 minutes in the CPAP mode with stable vital signs and oxygen saturation, and you have a rapid shallow breathing index of less than 105. What if the patient fails breathing trials? What do we have to do to help them to succeed? Well, we can go back and ascertain whether or not we feel that we've fixed the underlying cause of respiratory failure, and if so, are there other respiratory reserve or respiratory demand issues that we need to work on. If a trial of spontaneous ventilation does not work, are there other approaches that we could bring to bear to more gently separate the patient from ventilatory assistance? Can we substitute a non-invasive or BPAP ventilator mode for invasive endotracheal assisted mechanical ventilation? And then, if we are not making any progress, is it time to consider long-term weaning protocols for which a tracheostomy would be helpful? When we talk about respiratory failure, we're talking about the inability of the respiratory reserve to supply enough energy to meet the respiratory demands of the system. And we can break this up into a number of different categories. On the supply side, we have central drive that may be attenuated by drugs like narcotics or alkaloses, which would prevent the patient from making vigorous respiratory efforts in an attempt to compensate for alkalosis with respiratory acidosis. At the neuromuscular junction, we have non-depolarizing neuromuscular blockers, which may be hanging around and preventing good respiratory efforts. And some antibiotics, such as aminoglycosides, can also interfere with the transmission from the nerve to the muscle. The muscle itself could be compromised by inadequate oxygen delivery, malnutrition, electrolyte imbalances, or hormonal imbalances. Corticosteroids can cause atrophy of the respiratory muscles. And if the patient is bucking the ventilator, there's dysynchrony with the ventilator, or excess levels of intrinsic PEEP, we may be promoting fatigue in this respiratory muscular system that's preventing the patient from meeting their demands. On the demand side, we may have problems with the elastic load, excess fluid, which could respond to diuresis, pleural or effusions or acidic fluid that could be responsive to drainage, or atelectasis, which could be responsive to airway clearance maneuvers. The resistive load can also be impacted by retained secretions and bronchospasm, for which bronchodilators may be helpful. Things that increase the respiratory demand in general include fever, pain, anxiety, anemia, excess carbohydrate load, or acidosis. Treating any or all of these in turn can decrease the demand on the respiratory system and give the patient a better chance to succeed of extubation. If at first you don't succeed, you could consider lowering your expectations, perhaps expecting a rapid shallow breathing index of 105 is not appropriate for this patient. Consider this in patients that are very small, very old, have a restrictive ventilatory defect, including things like obesity, pregnancy, or pulmonary fibrosis. We can change the trial, decrease the amount of time that we expect, or add some inspiratory ventilator support during the trial with things like endotracheal tube pressure compensation, or adding 5 to 8 centimeters of pressure support ventilation during the spontaneous breathing trial. If spontaneous breathing trials are resulting in a lot of anxiety or excessive distress, then we could try to wean the patient in a more gentle fashion, i.e. not throw them into the deep end of the pool. Some ventilators have closed loop protocols that will automatically decrease amounts of pressure support ventilation as long as preset criteria for ventilatory adequacy, such as tidal volume, respiratory rate, and end tidal CO2 are met. our Draeger ventilators have such a closed-loop protocol that's called Smart Care. We can also take pressure support, gentle weaning mode on our own and do that over many hours or days to see if we can slowly separate the patient from positive pressure ventilation. Or if we do not seem to be able to get the patient separated from the invasive positive pressure ventilator in a timely fashion, and the airway is competent and secretions are not an issue, we could extubate the patient to BiPAP and continue to try to wean with a non-invasive ventilatory assist strategy. If we are at the point now where the breathing trial has been passed successfully and the patient is deemed to be at low risk to have failure of a trial of extubation, we need to think about the bad things that intubation can do to the airway. We need to check the gag reflex to make sure that airway patency can be maintained once the endotracheal tube is removed. Swelling can occur with irritation from the endotracheal tube at the level of the larynx, and if, when the cuff is deflated, air cannot be heard leaking around the outside of the endotracheal tube, or an air leak cannot be identified in the mechanical ventilator, we may be dealing with laryngeal edema, which will need to be addressed with corticosteroids before the endotracheal tube can be safely removed. Lastly, inspissated secretions can build up with the presence of a foreign body in the trachea interfering with mucociliary clearance, and we need to know first how much secretion the patient is burdened with, and this includes not just the amount but also its viscosity and its ease of clearance, and then how good is the patient's cough. Are they able to clear their airway sufficiently? Can they cooperate with coached coughing? All those things are important to assess prior to extubation. Even excessive salivic drainage into the upper airway can be something that leads to a failure of a trial. So, to have the process in overview then, we know that if the cause of the respiratory failure has been reversed and we have a competent airway with a reasonable respiratory reserve to meet the patient's demand, we can do a breathing trial. If the breathing trial is passed, we will assess our airway. If it's failed, we will rest the patient for 24 hours and retry. If the trial of extubation is passed, once the airway is deemed competent, then we are done. If the trial of extubation, then the patient needs to be reintubated, and we need to evaluate the reason for this failure. If we decide to extubate, what respiratory therapy adjuncts do we need to bring to bear once the endotracheal tube has been removed? If the patient is at very low risk for reintubation with low oxygen requirements and PEEP requirements, a low flow nasal cannula is probably sufficient. If the risk for reintubation is medium, if there's some need for PEEP or the FiO2s are in the higher range, then a high flow nasal cannula has been shown to be beneficial in terms of preventing reintubation. If the patient is at high risk for reintubation, has severe COPD, obesity hypoventilation syndrome, or hypercapnia, then extubating the patient with the assistance of BiPAP is a reasonable gambit. However, one has to realize that secretion removal may be attenuated with BiPAP, and so low secretion burden patients are probably going to do better with this assistance device than somebody with a lot. If you cannot extubate the patient, then you need to consider moving the endotracheal tube from supraglottic to a tracheostomy site. You want to do this to prevent permanent damage to the larynx. the first thing you're going to do is assess whether the underlying problem, is likely to be fixable in a 2 to 3 week time span. If the answer to that is no, severe malnutrition, volume overload, a massive variety, CNS problems, then there's no reason to wait for 2 or 3 weeks. Early tracheostomy may be in the patient's best interest. If they have a problem that's presumably fixable in 2 to 3 weeks and they're making progress towards independence, then the magic number of 2 weeks is probably too soon. You want to delay the tracheostomy and give the patient time to see if they can become independent without a surgical intervention. If, however, at 2 weeks there seems to be no progress, then delaying the tracheostomy is unlikely to be in the patient's best interest. To summarize, precision extubation means taking into account a number of different processes that will be necessary to assure that the patient can meet their demands with their respiratory reserve and have a competent airway as well. So you want to extubate people as soon as possible once the reason for respiratory failure or airway incompetence is reversed and you deem the risk of reintubation to be reasonably low. We need to get this endotracheal tube out because positive pressure ventilation is a necessary evil that has to have a finite endpoint. Breathing trial protocols seem to give us our best chance to remove the endotracheal tube in an efficient and timely fashion with a rapid shallow breathing index as our guide. However, remember this guidepost is somewhat suspect. If the breathing trial protocols are not working, keep an open mind about other alternatives that can help you to separate this patient from positive pressure ventilation and endotracheal intubation. Thank you for your attention. I hope you found this slideshow